Welcome to the Diabetes Podcast, where real stories meet real science, helping you take charge, not just take medicine. Today we're joined by a powerhouse in diabetes care, triple board certified physician Dr. Cheri Ogwo, endocrinology, internal medicine, and obesity medicine. In this conversation, Dr. Ogwo shares how she personalizes care from the very first visit, starting with listening, then taking swift and thoughtful action. We dig into lab work beyond A1C, insulin resistance and inflammation, practical low-carb strategies, CGMs and pumps, navigating insurance hurdles, and the mindset shifts that make sustainable progress possible. Whether you're newly diagnosed, long on the journey, or supporting someone you love, this episode is full of clear guidance, compassion, and real-world tactics you can use today. Let's go. Hello and welcome to the Diabetes Podcast. I'm Richie.
And I'm Amber.
And Amber, today we are talking with Dr. Cheri Ogwo. Dr. Ogwo, welcome to the podcast.
Thank you. It's glad to be here.
Awesome. So Dr. Ogwo, you are triple board certified and you do endocrinology and internal medicine, which is just amazing. So when somebody with diabetes, a person who has diabetes walks into your clinic, what are you paying attention to first and foremost with that person?
Okay, so it really depends on an individual. I try to get people to talk first because it tells me where you are.
Where your headspace is.
Exactly.
Sure.
Tell me where you are first. So because some people coming and they're like, oh my goodness, I am ready to battle this. Let's duke it out. And then some people are like, I don't believe it. I'm here for a second opinion.
Mm-hmm.
And some people are like just very distraught. I can't believe this is me. My mom had this. I said this was never gonna be me. I can't believe I'm in this position. So I start with just trying to see where everybody is first, because that kind of lets me know the first thing to focus on.
Got it. And are they doing their lab work prior to coming to see you? Ideally, I imagine some people show up not having it done. Like what's the difference between people who show up prepared with their lab work and people who don't, and the approach you take there?
So I'm assuming you're talking about new patients, right?
Yeah, new
New
and
patients.
established, because established, they need their periodic lab work still,
So established the rule of a thumb in the clinic is you have to come a week before. So most people do try to follow that rule because it ends up being a more productive and fruitful visit for you. If we have labs and we're going over the labs, and in our clinic we really do dig into labs. I mean, endo is a very lab focused specialty. So it's not just your A1C. We're talking about the protein in the urine. We're talking about your creatinine. We're talking about the cholesterol. So we really do dig deep into your lab and not just, hey, your A1C is this. And then of course we're comparing your A1C to your finger sticks, because some patients are just very surprised. How can my A1C be 10 every time I check my blood sugar at home? It's always 120. It's never more than 120. Then, of course, we start kind of trying to delve. How many times are you checking? Are you checking just first thing in the morning? Are you checking after you've eaten? Because A1C is an average. It's not just, yeah. So maybe you're fine in the morning, but after you've eaten, we then start spiking. There's got to be a reason for that 10, which then also helps us to tailor the therapy, whatever changes we're going to make. Are we focusing on fasting sugars, or are we focusing on after meal sugars? So our established patients know that, and they know it works out better for them. It's a more productive visit if they come before. But for our new patients, sometimes they would come with labs. A lot of times, actually, especially if someone referred them, they would come with labs. But the self-referred ones usually would not come with labs, but we would get labs the day of the visit.
Oh, good.
If they
So
came
you
with
do
labs,
you do a point of care A1C at least to have
we
that?
do a point of care sometimes. And sometimes, but then we always also do get the full panel.
Wonderful. Good.
Yes, on that first visit. Um, Depending on if they're established as far as established, that's not a good word. If they have a known
It's
diagnosis
a
of
it's a word
diabetes.
that is used in
I
medicine, I
was
guess
going to say
yeah.
established if they have established diabetes, but yeah, but
Oh.
if they have a known history of diabetes and they're already testing, then
Okay.
we can also use their finger sticks or their Libre data, the CGM data, to come up with a therapy plan. If, however, they're newly diagnosed, not really testing, then obviously we need a baseline. But the we never, I mean, of course, we'll do a point of care, like you said, A1C, and then also finger stick in the clinic, depending on how high it is. We always try to start people on something on that first visit. It may not be a very personalized regimen or too detailed, but at least we start you on something, and then we'll have them come back in about 2 or 3 weeks with labs, with new data, and then we come up with a true plan of care.
Love it. So what if what do your patients usually feel about that when they come in and you're quick to y- it the recommendation is that you're in a big problem within endocrinology and primary care is this idea of let's wait and see, but you're like, no, we're going to tackle this right away. But I also understand that a lot of your patients might push back to
Mhm.
that. So how do you frame it with them? How do you let them know that we're already behind at this point, without,
So,
especially in the first visit where trust is maybe not established as well?
right. So I'm not a big fan of A1C inertia. Um,
Hmm.
I
Clinical
just
inertia. Hmm.
Yes, I just absolutely hate it where people come in and tell me, "Oh, but my PCP told me this, my A1C of 8 is good."
Mm,
So, but and that's also part of where letting them talk a lot. So in my first visit, you do the bulk of the talking. I'm just asking a few questions here and there because it's building the trust. It's building you are heard. And I
okay.
understand exactly what you're saying. I mean, okay, I haven't lived it, so I can't say I truly understand, but I empathize.
Mm,
And I know how hard this diagnosis is and how much it disrupts your life.
yeah.
And then when I bring up the regimen and I get a pushback, usually what I will say, and which is always true, I tell people that my goal from today is to try to get you on the least amount of medication that I can. So even though we're starting with this, at every visit, we are looking to see what we can remove and what we can take
Mhm.
away. I just need you to work with me, do your part. Of course, we can kind of get into the diet and the exercise and all that. And then as we're doing all that, then we will start getting rid of this medication, a bunch of these medications. We may not be able to get rid of everything, but we'll get rid of as much as we can and still maintain your A1C where it needs to be.
Mm. I love that because we often talk of the meds as scaffolding while you build the building.
Yeah.
Awesome. So, how do you personally think about type 2 diabetes? Like, what do you believe type 2 diabetes is at its core? To explain it at its core, how would you do that?
Okay. So type 2 diabetes, um, honestly, is a disease of inflammation.
Hmm.
It's a disease of insulin resistance. So the high sugars we're seeing is because of things that have been happening in the background for years and years and years and it's gone unchecked. And now we're seeing the sugars and we're focusing on the sugars. But the sugars aren't necessarily the problem. The sugars are a side of is what you're seeing is like when you see an iceberg, you see the tip of the iceberg, but the bigger part of that iceberg is underwater. So until you go underwater and fix that problem, the little tip you're seeing is nothing.
So
So
well said. Mhm.
that's the way I see type 2 diabetes, the disease of inflammation that ultimately leads to insulin resistance.
Mhm. I love it. And how has this understanding of diabetes evolved over your career? Because I don't imagine it started that way and then you've got so much more clarity with this. How did that come to be? If you can put that into words, I know that's probably challenging.
And honestly, it was over time. So even when I was a fellow, graduated fellowship, it was just, diabetes is high blood sugar and all that. But as I kind of started delving more into obesity medicine and also developing more of my own um interest to where it's become more of a passion to me. So something that I'm truly passionate about. Uh, so at that point, I had to go but beyond the surface knowledge to, what is a true driver for this? So experimenting with my patients has been very helpful, obviously, because I mean, sometimes I
Shh,
will do
don't
it,
tell them they
I
were
know,
guinea
right? And I
pigs.
tell them, I'll tell them, this, um, and over time, and that's kind of changed a little bit of my practice also because I've been practicing actively since 2020, since COVID. Um, and initially it was, of course, just, those are the medications that the guidelines say you start with, and so we start here, and then we scaffold, we add this on top of it. But now more so of my practice is, and I would ask people, so kind of tell me what you struggle with. So it's almost like I try to personalize the regimen I'm going to start with to what you're struggling with almost.
Mm,
So to try to pair you with the medications we have and how it helps you. So I'll give you an example. Maybe someone that has um maybe A1C of 14, um, maybe struggling with weight, and see I have you on insulin, I don't know, let's say long acting 50, short acting, you're on 20 3 times a day, and I know you're doing what you're supposed to do. And then you come back and your A1C has gone from 14 to 13.5.
Jeez.
you're not taking those shots. Yeah.
You are taking the shots because everyone around you is telling me, honestly, she does take the shots. Now, it's no longer a question of increase the dosage. It's now a question of there is
How do we get rid of the
underlying
resistance?
insulin resistance here.
Hmm.
How do I
Got
address
it.
this insulin resistance without just increasing her insulin um uh, dosing that ultimately worsens the insulin resistance?
Right.
And then we're just chasing our tails.
Mm. Love, that's awesome. That is awesome. Okay, so when you're looking at that out in the ACE algorithm,
Mhm.
that's the Association for Clinical Endocrinology, what is recommended? They've got the diet and exercise umbrella overall. But usually by the time someone sees you, they've tried diet and exercise, maybe not the best systematic approach working with an experienced dietitian, diabetes educator, but they've at least tried something, and they come to you. So you're already thinking, I'm going to add first line therapy. Is that always, you said you tailor it, but it depends on the A1C, I would imagine, because if
Mhm.
it is recommended in the algorithm, if somebody's over a certain A1C, that you go to insulin to get that A1C down. So, usually metformin plays a big role in the first line of things that you get, but there's also a lot of pushback from things people have heard on the internet about metformin. How do you have that conversation with your patients? What are your personal thoughts about metformin? Like, I'd love to hear how you overcome that with people.
So metformin is not necessarily a number one, a step one therapy for me. It not necessarily is. So like I said, I listen to my patients quite a bit because the medication I give you that you don't want to take, that you're already resistant to, you will not take it.
Oh, so
So
well said.
I'm just
Mm-hmm.
wasting my time and your time
Mm,
and killing your kidneys in the process. But, I also try to correct that misinformation that metformin causes renal disease because it honestly doesn't.
right.
Metformin has been there for longer than I've been alive, honestly. And and it works, but it works for what it works for. it's a pretty good sensitizer. If I need to sensitize someone, I will use metformin as one insulin sensitizing as one of the medications that I may use. Now there are others that are a little bit stronger, but I do use that as a sensitizer when I need to. Um, I do tell patients that metformin does not cause renal disease. However, the problem starts when people have a lower GFR and their doctors are not paying attention to stop that metformin. Now, yes, it can speed up that renal problem because of lactic acidosis and everything else that it can, or metabolic acidosis that it can cause. But so long as the kidney numbers are doing are where they need to be, and someone is paying attention, I think the guideline says 35. I stopped metformin at 45 personally because at that point I'm trying to see if I can reverse. Right.
Yeah. Yeah.
Um, so. I tell that to them, but also a lot of times it's not even about the kidney problems. It's people saying, I've tried this before, it tore up my stomach, and I
Mm.
just can't take this anymore. And if you already have a very high resistance to a medication, then there's no point in trying it again. There's no point in trying to see, oh, let's see if it works this time, or let's see if extended release would help you. And it may help some people. Um, Now what I will do sometimes is, for example, if we're starting them on a combination medicine that has
Mhm.
metformin, I could tell them that let's try this combination. It's extended release. The metformin is there, but it's a lower dose, and let's see how it works. I'll have someone call you in about 2, 3 days. If it's not working out for you, and usually I'll give them a sample at that point, because people feel better when they're not wasting their money on something they feel like it's not going to work for them
Right. If this
anyways.
doesn't work out, I haven't, yeah,
Exactly. If
wasted.
I have a sample, I'll give them a sample. I tell them I'll have someone call you in about 3 days. If you're struggling with it, we'll change it.
Mhm.
And that usually would work. And most times when we give them a call, they're like, "Oh no, this is working really well. You can go ahead and call it in." That's usually the response we get.
Okay, I have a question around that because oftentimes if you're choosing a drug in a class, insurance will dictate to the
Mhm.
patient, we're only covering one drug in this class. So when you give somebody a sample of, let's say, like Zigduo XR, which is your Farxiga extended release metformin,
Mhm.
and maybe they're only going to cover the Jardiance version, of that. What, like Synjardy or something. So
Mhm.
do you tell them like this is the sample you have, but these are the other drugs in the class that if insurance doesn't cover this one, ask about this one and this one? Like, are you proactive in that space, or do you wait until they come back to you and say this medicine you, because they can get, I've noticed people can get upset when, oh, you said this drug and I like it, but now it's $700 a month. And
Mhm.
then that creates a lot of like, anger,
Yeah.
misplaced in my opinion, but it's due to just not really understanding that probably a different drug in the class is covered. How do you manage that with your patients?
So, to a certain degree, we try to mitigate that as best as we can. So, our EMR so before we even give you any samples, my EMR would kind of let me know what's on formulary and what isn't.
Okay.
Now, PAs, we have someone that's excellent at PAs in my clinic. So, if it doesn't a PA, we'll push it in on right away and have her start working on the PAs. Now, the bigger problem is when they tell us it's covered, but then the deductible ends up being just
Oh,
astronomical.
those deductibles. Yes.
Exactly. You
And
get to
people
the
don't
pharmacy,
understand that. Yes.
right? You get to the
Mhm.
pharmacy and they tell you it's now $500. I mean, it was on the formulary. I've done the PA, but we had no way of knowing that it was going to end up being 500 because even within the same uh insurance plan, a plan,
Right.
I would
Doesn't
say,
matter what drug
that's
you choose, that
right.
deductible is going to be there. Hmm.
Right. And for example, let's say someone has Blue Cross Blue Shield. Blue Shield has a ton of plans under their umbrella, and different plans are different. For some people, it might be $25. For some people, it's 100, and we have no way of knowing what type of plan everyone has. I just know that Blue Cross covers this. We've done the PA. Now it's for you to tell me. But we also tell them if you get to the pharmacy and it's just ridiculously expensive, let us know.
Hmm.
At that point, what we do is we call the insurance and ask them for what's on their formulary. That's reasonable, and we try to tailor it if we're able to. Um,
That's a lot,
Now
and that's a lot of work
it
on the clinic
is.
staff.
It really is. And the funny, and it's, patients don't really appreciate the amount of work it takes in the
I'm nodding
background.
my head so big right now.
Yeah.
Yes.
Because sometimes they call you, why isn't this PA done? Why is it? And I'm like, you know what? The PA is done, but still your insurance company still has to approve it. And
Mhm.
then sometimes we still have to, they deny it, and then we still have to appeal. So we don't have to always come back to you and tell you, oh, your PA is denied, now we're appealing. Because all we're trying to do is get you the medication that you need.
Mhm. And for those of you who are not aware, PA is prior authorization, and that's, think of it like a hoop to jump through before the insurance company. Maybe they might want to have your physician prove that you've failed metformin or prove that you've failed other medicines before they put you on a different type of medication. And yeah, we could go really into the weeds about why these even exist in the first place, but it's
So,
not the purpose of this
so I got
discussion.
a question. I mean, to me, again, as the layperson, this sounds like a huge pain in the butt for both the patient and the provider. We love to talk policy because there's an opportunity for at scale to make things better. If you had a magic wand and can fix it, is there a better way to do it in your opinion to get the patients the care they need without an egregious burden on the provider?
You solve that problem, Richie. We're we,
Oh, I, I
we are
I
going.
have ideas, but they're just not, they're really,
Let's
unfortunately,
hear them.
capitalism.
Yeah.
And it's greed in capitalism because I'm a capitalist at heart too. I believe everyone that works should make a fair wage, and you should
Hmm.
work
Yeah.
as much as hard as you put in. You should make that amount of money. But my thing is, if you have to, and it's okay to increase the premiums a little bit if that's what it takes. But if I'm paying a premium every month, then I should get what I need. I shouldn't
Yeah.
have to fight for
Ooh.
it. I shouldn't have
Mm-hmm.
to, I shouldn't have to, I shouldn't have to prove that I need it. If my doctor says this is what I need, then honestly, I feel like because I've paid for this, then it should be given to me.
And that's where people get really angry
Right.
because they do feel that way. And there's the way that I believe most of us feel that it should be, and then there's the way that it is.
Yes,
And
absolutely.
that disconnect is really frustrating.
It is.
And anybody listening who has dealt with this knows exactly what we're talking about. Oh my
Yes.
gosh. Wow. So when patients hear that they need another medicine, let's say they've come in and you've started them on something and then they come back and that A1C is not at goal, especially like coming back to that example you gave of the patient on basal bolus therapy and they're taking their shots and their A1C is still too high and you're adding more. There's often frustration and fear. So how do you approach these conversations with people?
So, and I tell them I tell my patients, we have two options. We can do it the easier way, or we can do it the right way. And to me, the easier way is adding more medicines. I'm an allopathic doctor, so I was trained to give medications, but at heart, I'm a naturopath. So, and I believe that problems should be handled at the root. And if the problem is insulin resistance, get rid of carbs and you'll fix it.
Okay, so we did an episode called The Case for Carbs. And
Yes.
so you can, if carbs
Mhm.
raise blood sugar directly, you
Mhm.
could do more of a ketogenic, you could reduce carbs and it definitely will fix this temporarily. But what do you do when the patient's been avoiding carbs and they still have high sugars and they are still struggling or they're struggling with adherence to that? What do you do when they come back with that?
Okay, so it's near impossible to continue to have high sugars if you are following a low carb diet. I'm an evangelist of low carb. I live low carb. I consume about 40 to 50 grams of carbs in a day.
Okay, good. I was going to ask like
Yes, ma'am.
what that definition is for you.
Yes, for me, and I don't have diabetes, but that's just because, and it's not because it's not even because carbs raise your blood sugars. It's because carbs trigger a pancreas response.
Mm.
I need
So,
to re
yeah.
the insulin secretion because when you think about insulin has two pathways. You have a pathway that is fixing or that is bringing down your blood sugars or correcting the high blood sugar by allowing the blood sugar to enter into the cells. But then you also have the anabolic or the part of the insulin pathway that is involved in cell growth and everything else surrounding that, including fat cell growth. So every time your pancreas is secreting insulin, you're creating an opportunity for insulin resistance.
Mm.
So, to get to the root of that is decrease the opportunity you give your pancreas to secrete insulin. Now, if your pancreas is no longer, I mean, so you're now on exogenous insulin, you're having to give yourself insulin, then the only way to decrease the amount of insulin you need is reduce the carbs that you're challenging your body with. So if you reduce your carb challenge, and eventually once you start getting deeper into it and start tweaking, and then you start tweaking fats as well. But to that becomes a little too deep. But reduce the carb you're intaking, and that obviously would help with um the insulin resistance that the body is facing. Now, but like you rightly said, there are people do struggle with adherence. And that's why I give them the option. You can go the easier way. The easier way is more medication. Now, I don't want to my job, my goal is not to give everyone I don't want to just keep adding on medicines and adding on medicines. However, I also want to make sure we're preserving those organs, the kidneys, the nerves, the eyes, and then sometimes I may have to quote statistics and diabetes is the number one cause of everything I've mentioned, number one cause of dialysis in this country,
Blindness,
number
number
one
one cause of
of blindness in
amputation.
this country, non-traumatic amputation in this country, four times increase in your risk of heart attacks and strokes. And this is on top of your already familial risk that
Right.
exists for a lot of people.
Yeah.
So, we kind of talk about that, and once again, just trying to reassure them. My goal is not to just keep adding and adding and adding. I want to work with you. Tell me what you want us to do. Tell me how we can get this number better. Tell me what you can stick to. And
Yeah.
and then you talked about difficulty with adherence. First of all, we'll have a great dietitian. And that's part of
Woo
our
woo.
yes,
Sorry, I
ma'am.
love the shout out to dietitians. I'm
Yes.
a little biased. Love it.
Yes. That's part of our care track. If you have diabetes, it's not optional.
Mhm.
And you want to stay within our ecosystem, then seeing our dietitian is just something that happens. If your A1C is where it needs to be, then you see him once a year. You don't have to see him too often, just to make sure we're still on the right path. We're still following what we need to do. If you have any questions, he can address them. If the A1C is not controlled, then you see him more frequently because that's part of your care plan.
I like
Um,
so you make it mandatory because it is part of their care plan. It's part of what is needed to
yes,
achieve the
ma'am.
outcomes that they've likely told you from all of their talking in the beginning where you were listening, that you have for them. That's
Yes, ma'am.
awesome.
That's correct. And then another thing is also, and he's very good at this, is making. But before we got him, I was doing all the dietary talking myself, and I'd find that it would take up about 90% of my visit because people
Yes.
see, and that's what I've kind of found. People really want to eat better, but people don't know what to do.
Right.
Sometimes they'll tell me I'm doing everything I need to do. I'm eating right. I'm like, okay, that's fine. Tell me what you ate yesterday. And then by the time they kind of
Except
go
yesterday, like, except yesterday. Hmm.
right, and when they kind of go through what they ate, and this person believes truly in their heart that they're doing the right things because no one has taken the time to tell them there is a difference between, you know, cardiac diet. If you have high blood pressure and you have um maybe heart attacks and your focus is trying to address that versus you have diabetes and you need to eat better for your diabetes. You're telling me I don't eat fried stuff. Well, that's great, but honestly, your pancreas couldn't care less. I mean, it's good for the heart, but you're telling me I don't eat fried stuff. I only bake my food. I only broil my food. Oh, well, that's great, and I applaud you for that. But we're still eating pasta. We're still eating, and pasta not as a side, but as the main item.
Mm.
And the goal is not, and I tell them my goal is not to take away everything you want or everything you love to eat, but we can start with baby steps. If we eat two slices of bread at breakfast, can we eat one slice? That's a start.
Mhm.
If we eat, and in the South, here in Tennessee, a good Southern breakfast is your toast and then your grits with rice and all. And I'm like, okay, can we pick maybe? And then of course you need your fruits and your orange juice too. Can we maybe pick one or two carbs and limit it to that? That's a start.
Can
So.
I, sorry, I want to ask about this because being in the South as well, what you just said are fighting words, Dr. Ogwo. So how do you how do you address this? Well, you got to die somehow. If I had $1 for every time I heard that, how do you address that mindset with yours and try to do as you say, like get them bought into the plan and bought into their identity as someone who doesn't follow the footsteps of their parents who had diabetes and had a leg amputated, or how do you manage that?
And that's a not a one visit conversation.
Hmm.
Mm.
And I tell them, yeah, absolutely, you got to die somehow, but does the death have to be painful? Because diabetes death is suffering kind of death.
I
It's
think
Yeah.
it's
not,
more quality of life for a
yeah,
decade or more,
exactly.
right? It's not the death itself. Yeah.
Exactly. It's not you go to bed and then you fall asleep and you die quietly in your sleep. That's not the kind of death diabetes gives you. It just slowly eats away at everything until you're at a point where you're maybe sometimes even begging for the death and the death is not coming.
Mm.
So I'm like, do we really have to go through all that? So, and it could be, and when I tell them, okay, so you gotta die somehow. Okay, and I'm like, okay, I hear you. Now, I mean, ask them to just give me one thing. And I'm very playful, so I play a lot with my patients, and I'll be like, okay, I got you. You're gonna die somehow. That's fine, but give me one thing. I need one thing from you, and you're not leaving here today until you give me one thing that you're willing to give up. Usually
Yeah.
they'll be like, okay, I'll give you the Coke. I'm like, that's fine, I'll take the Coke.
Yeah.
And next time
Yes.
we'll talk something else. Give me something else. And eventually, slowly but surely, especially when they start feeling better.
Yeah.
Mhm.
And they come and like, Doc, oh my goodness, I feel so much better today. I'm like, I know. So give me something else. It becomes easier.
And do you notice that their energy levels, the feeling of the inability of the sugar to get inside the cells to create energy for them, do you feel that develops so slowly that oftentimes people don't know how bad they feel until they feel something different, until they start to see improvement?
It does. And that's exactly how my patients will describe it. They'll be like, oh my goodness, I didn't know I felt this bad
Mm,
Mhm.
yeah.
until I started feeling better. I thought this was just how it is.
Yeah.
I'm
I'm
getting
just getting
older.
old now.
Exactly.
Yes.
I'm getting older. So this is how it is when you get older until I start taking this medication, until I started doing this differently, and I just feel so much better now.
And
Yes.
and I think what you said is kind of valuable to highlight that in that when you start doing things that actually start to combat type 2 diabetes, healing can actually take place quicker than the disease manifested as it rolled out. It's never going to be an on off switch, where I instantly feel better. But
Mhm.
you can start to feel better in a matter of weeks, where this took years and years and years to get to this point.
That's correct.
Absolutely. And
So
we
we
just,
try not to get too much into the how, because that varies for individuals. So we generally speak in big brushstrokes.
Mhm.
Um, but the second you start talking low carb, I think a lot of people immediately go to keto, they go to carnivore diet, and a number of these. Um, there are.
more extreme
Yeah, it's
sides
great
of
great
that.
for your insulin resistance, but there may be other things that are perhaps not positive. What does a typical day look like for you, someone who practices what she preaches? Um, how do you get the fiber? How do you get the micronutrients? All of the other stuff that typically immediately drops out, specifically the fiber, when you start going to a low carb diet.
So a low carb diet doesn't necessarily mean a high carnivore diet or a high meat or high processed. So even though I eat low carb, I also eat low processed.
Hmm.
So I eat lots and lots of veggies.
Hmm.
So a meal for me, and I don't eat 3 meals a day. Also it's for also because of pancreas rest. But so a breakfast for me could be, if I eat anything at all, it could be maybe 4 boiled eggs,
Okay.
and or I would only eat one or two whole, and the others I just eat the whites.
Okay.
Um,
But Dr. Ogwo, your cholesterol, I say that tongue in cheek
yes,
because we just
ma'am.
did a cholesterol issue about how it's not dietary intake of cholesterol.
Right, right.
I
And
tongue
then
in cheek.
and
So
exactly, but then also that's why I'm not eating all 4 egg yolks.
Hmm.
It makes me feel better not to eat all four. And
that's
then
saturated fat. Yeah. Hmm.
yes, it is saturated fat. Um, Lunch, maybe nothing because I'm busy.
Hmm.
So, then dinner, this is kind of where I eat the bulk of my meal, but that bulk of my meal is mostly broccoli
Non-starchy
and
veggies.
cabbage,
Hmm.
green beans. So that's just a lot of that. I may add chickpeas for protein. Now
Okay.
I may add salmon for protein, but just things like that. Now I may add chicken too sometimes, but here recently I'm not a very big poultry eater. Um, right. But that's how I get my fiber.
Okay.
I also believe that anyone that's eaten the average American diet, especially the average processed American diet, you need to be taking a
Call it the
good
sad
multivitamin.
diet.
Yes, you should be
Mhm.
taking a good multivitamin because there's so many micronutrients you're not getting. So I do take a multivitamin too. Not every day, but some days to supplement.
Yeah. And I'm sorry, didn't mean to speak over you. It's
That's
called the
fine.
sad diet for a reason, the standard
Yeah,
American diet.
right. Yes, ma'am. The sad diet.
Mhm. So, if you have somebody who comes to see you, maybe not one of your repeat people, because it sounds like once someone's established with you, they have a better outlook. But when you have people who feel like they're failing, like the fact that they have diabetes is a failure, or you asking them to add scaffolding in the form of medication feels like a failure, how do you, well, first, what do you see driving that emotional burden? I would imagine it's probably the fact that they're low energy, but other things maybe. And then how do you help patients re-engage when they really feel like there's low hope or they feel quite defeated?
Yeah. Um, you know what? And this is especially true for people that have had diabetes for a long time. What people don't think about a lot is the fatigue and the hopelessness that comes from chronic disease.
Yeah.
Because when you've done something over and over and over, and then sometimes also it feels like just nothing you're doing is working. Um, to even take it away from illness, just think of if you're at a job and you're working this job and you've been, let's say you're in a bank and you've been a bank teller for 20 years and people around you are getting promoted because you have peers that are saying, oh, I'm doing this and it's working for me. And then you're trying everything and you're still a teller and you're still making the same $5 an hour. And
Oh, we
nothing
hope
is,
not.
from 20 years ago. And
Yeah,
nothing
yeah,
is
yeah.
getting better. I'm just trying to, but that's the outlook. And nothing is getting better. You feel like you're putting your best, and just nothing. You're just stuck at the same spot and nothing is improving. So the first thing usually is, we reframe it. You did not fail. It's not a reflection on your person. It's not a reflection on who you are. And I could start delving into things and saying, I bet you it's probably because you didn't know about this. Or maybe you haven't been on the best therapy you can be, and maybe we can change up this combination a little bit without even increasing the number of medicines you're taking. Maybe if I can add this and take away this and add this and take away this, we can come to a place where we at least get. And I know that maybe doing that may not get you to a 7, but what it does is it pulls your A1C down a point or even 2 points, and then suddenly you're more hopeful and you're now more willing for me to do whatever I want to do.
Yeah,
Yeah,
I
because a
like it.
lot a lot of people, it's not even about the fact that I'm taking 3 already. I don't want to take any more than 3. What can I do within that 3? Keep it at 3. How can I move things around? Keep it at 3 and still get you better outcomes? Because there are ways.
So,
So,
what's the big deal? You and I know this, but for people listening, what's the big deal about A1C? Why does it matter so much if my A1C is a 9 versus a 7? Who cares?
so it's not, and it's not necessarily. So A1C just what A1C does is it gives us a quick number, a quick average to kind of tell us which direction a person's control is going. But as far as the actual number, it actually matters more than A1C because when we're treating people, once I get your A1C to 7, I'm no longer focused on your A1C. I start to focus on your daily numbers because the it's and I think the research says 200. Every number that's above 200, doesn't matter how long that number, that the duration of time that is, you're damaging organs, you're
Mm.
damaging nerves, you're damaging cells, so certain cells that you really cannot recover. So it's not really even until the A1C is at 8 or 9 or 10 and stays there persistently. But obviously, we know that if you're having higher A1Cs, that means that now you're staying in those higher numbers much longer than we would love you to. So the A1C just gives us a very quick snapshot of what you've been doing over 3 months. And we know that the higher the A1C is, then the longer you're living in territory we don't want you to be at.
So it sounds like you're, especially at lower A1Cs, you're really looking at that glucose variability. How high are the highest highs? Like, are you really riding that roller coaster up and down, or is it more of a
That's
steady? Because
correct.
you could have a 7A1C. Two people can have a 7A1C and look completely different in
That is
terms of their
correct.
highest highs and their lowest
So
lows. Because you
lows.
could have somebody 20% of the time hypoglycemic with their blood sugar below
Mhm.
70 that's pulling that A1C down.
Yeah,
Meanwhile, they're living above 200 a good percent of the time as well.
that is correct.
And I think it also illustrates the importance of, you know, particularly if you have a high A1C, the importance of getting on that medication as quickly as humanly possible to bring that A1C down. A lot of medications on the product can almost reduce it by a whole point. If I'm in the 8s and I can get close to that 7, now I can start focusing on more the nuanced stuff. But that is a very quick lever that we can pull to
Yeah.
to kind of push that in the, immediately push that in the right direction.
Right, but just to something that was said earlier, but also the problem with diabetes. which is why sometimes we also get that pushback, even with the higher A1Cs, is it's not like I don't know, it's not like migraines where if you have a headache, you feel like you're about to die.
Hmm.
It's one of those, but I feel okay. So it can't be
Mhm.
that bad. And then so people are not as um aggressive as wanting to make changes or take medications because I still feel okay. But even though the A1C is 10, well, the problem is that when you now start not feeling okay, at that point it's probably too late. Yes, I can pull that A1C down, but the cell's already damaged. The
Hmm.
neuropathy is here to stay. The kidney damage is here to stay. We're at a point where we cannot think we're no longer able to reverse things because we started therapy on time or we start trying to fix the numbers at a more aggressive pace.
Yeah. Being that you do look more at natural ways to help, when we talk about sleep and stress and some of those less visible drivers of blood sugar, beyond the labs and prescriptions, like what do you recommend? Do you talk about stress and sleep with your patients? Do you have time to talk about that? And what do you find being the biggest issue? Because one thing I've noticed is a lot of people who have type 2 diabetes wake up in the middle of the night to eat, disproportionately so than the general population, I would say. Do you notice this or have
Oh,
thoughts here?
so as far as the stress part, yes. Because we do talk about stress and because sometimes my patients will be like, I didn't eat anything last night and then I woke up this morning, my blood sugar is in the 200s. Then when I might ask them, okay. Now if it's someone that maybe that hasn't been their pattern. And I know that it's not because of the hepatic, gluconeogenesis problem that comes with diabetes. It's someone that has been well controlled or is taking a medication that maybe insulins. There's no reason why you should be waking up with morning high sugars. So I may start with, okay, tell me about your sleep for the past month. Tell me about your stressors at work. And then usually, they start going into it, are like, yeah, my life has been a lot more stressed, or, my husband is sick, or this is happening, that is happening. I just got laid off, or I'm worried about money and all these other things. And at that point, I'm like, yes, it's a cortisol that's driving the high sugars we're seeing. Of course, it's not like stress is an on and off button. So I
Mhm.
can say stop being stressed. And then they stop being stressed. So at that point, we start talking strategies, maybe. What are ways we can maybe reduce the stress?
Mhm.
Which, walking is a very good stress reducer. And you don't even have to walk a long distance, even 10 minutes, especially if you can do it out in nature. Very, very good stress reducer. We talk journaling. Tell them start keeping a journal. At the end of the day, just write something that if you can, even if it's only one thing you can think of, write one thing you're grateful for. It helps reduce the cortisol. It actually even that remembrance, that recalling helps increase your dopamine. So we start talking other hormones that you serotonin also that you can kind of balance out with certain things. Meditation, listening to music and just dance just uplifts your spirit. Yeah, the
Mhm.
stressors are still there, but there's some things we can do to modulate the hormones and their response to it.
And to physically move that stress out of your
Yes.
body too. Awesome. Okay, so let's move a little into technology and go there because in the beginning you talked about finger sticks or continuous glucose monitors. How have you used continuous glucose monitors in your practice and how do you feel about the changes that they make in your patients and having so many more blood sugar numbers throughout the day? Can you speak to that for people who are unaware of what they are and how they're useful to you?
Right. So I'm a big proponent of continuous glucose monitors, whether it be Libre or Dexcom. I support it. I'm a big supporter. I we try to get everyone that we can on it, and mostly because of the self-awareness component. Not necessarily so you know what your sugar is doing every second of the day, but knowing how things you do and situations around your life affect your sugar.
Mhm.
So helps you be more aware, and then hopefully you're a person that would do something with that knowledge.
Yeah.
Right. Because I have
Yeah.
some patients that tell me, oh, yeah, I know that whenever I eat this oatmeal, it spikes my sugar, but I still eat it anyways. You have some people like that, but at least you know. So it's a choice you're making now to keep doing that. Um, Now, on the other hand, you have some people on the other extreme that it becomes more of a problem for.
I know. Yes.
Yes. I have a patient
'Cause
that
yeah.
calls us literally every week. "Oh, my
Hmm.
sugar is 90 again. It is too
Oh
low."
my goodness.
I'm like, it is perfect. We are happy with this 90. And then she'll stop taking her medicines because now it's 90 and it's getting too low. So you
Mhm.
have people that also get into the anxiety, causes a lot of anxiety for them, and they're watching it every second. And and for those people, what I do is I we may silence the alarm,
Mhm.
especially when they're not at
They're not
rest
on insulin. Hmm.
and they're not on insulin, they're not at risk for hyper or hypo. We silence the alarms just to kind of give them a break, and hope that maybe they'll forget it enough and not keep looking at it. But overall, though, I think it's honestly been a game changer for the field of diabetes.
Hmm.
Especially also for people that, I know when we talk about diabetes a lot, we focus on type 2s, especially for people that have type 1
Absolutely.
that end up having hypoglycemia unawareness. So it's been a total game changer having something alert you before you get too low to where you can't help yourself.
Right.
Right.
Right. And can we talk about hypoglycemia unawareness in the setting of neuropathy, especially for people who have type 1 diabetes? If how dangerous it can be for them to suddenly not feel lows, or if they're low a lot, to not recognize no lows as quickly as they used to, because that's something that comes up a lot, that people say, I used to feel the second I was below 70, I knew it. And now I'm 45 before I feel
Hmm.
anything. And so I rely on that continuous glucose monitor to tell me.
Hmm.
What strategies do you have for that person to not wake up 10 times during the night, or alarms, or because shutting them off is not
It's not an option
necessarily,
here.
yeah.
So what we do in this setting is we'll let them run high for a little bit. You actually reset that quite quickly. So I tell them, you know what, we're not worried about your how high you are. I just need you to run a little higher for maybe a couple of weeks to 3 weeks. Let the body experience a number of highs so that it becomes sensitive to lows again.
Mhm.
And usually that does help.
Yeah, I think that's an excellent strategy in theory, but typically people with type 1 who are used to being low
Mhm,
are, it's really hard to get them to accept anything over like a 150 or 180 for any period of time. They freak out. How
mhm,
do you ease their mind and like, please just trust me that we need to be on, like, no, we need you to experience zero hypoglycemic events for some
mhm.
time.
Yeah.
Like, how do you win them? How do you do this? Because this is, whoo.
Well, it's just, trying to calm the fears. Like, what are the fears? They're so scared that they're going to develop neuropathy. I'm going to end up on dialysis. Just calming those fears. You don't end up on dialysis just because you ran high for 3 weeks. We're only doing this temporarily. In fact, if you'll trust me enough, let's take away this sensor for a little bit. Just do your finger sticks as you were doing before the sensors became a thing. So that way you're not so, because it becomes a little obsessive also, for especially for those type ones that insist on being less than 7. There's no exactly. So let's take away the sensor for a little bit. Just do your finger sticks like you were doing. Um, Obviously make sure you're taking your long acting. I may reduce their carb ratio, or actually increase their carb ratio. So to where, if you were on 10-1, I may go ahead and just make it a 15-1 or a 20-1, just to allow for that slight I'd like you to run high slightly, but at the same time, I'm not trying to get you to 300s or 400s because then they'll just have a, yeah, they'll just pass out for me if we run that high. But at least try to get you into the 200s. And also, I've also noticed that when people feel like they're doing something, for example, if you still have you're still giving your insulins like you would, um, it makes you feel like you're responding. I'm high, so I take this insulin. We may end up doing if they're not on a pump, we may end up doing more of a correction factor. If you check it and it's high, go ahead and correct. But of course, it will be a very gentle correction. But that way, you still feel like you're involved in your care and you're still doing something in response to this high.
Yeah. Yeah. So speaking of insulin pumps, insulin delivery systems, the newest 2026 guidelines coming out from the American Diabetes Association recommend automated insulin delivery devices for all people who are insulin dependent, especially on rapid acting insulin. How do you feel about those guidelines and then the practicality of being able to get everyone requiring insulin on these? Like, what are your thoughts here?
Well, if you're so for our type ones, I try to get everyone on a pump if possible. For pregnant patients, also on a pump.
Hmm.
Um, I think requiring everyone to be on a pump or something like that is very unreasonable. It's almost like you don't live in America because they're expensive.
It
And
can be. Hmm.
yeah, actually for unless you are on some kind of government
Hmm.
um insurance, the copays end up being a good reason why a lot of people choose to stop taking it or
Hmm.
using it. So now I have to
Yeah,
choose
if you're on
between
a
my
fixed
fixed
income,
income.
some of these even at $75 a month, on
Mm-hmm.
top of the $75 a month for a CGM, on top
CGM,
of
exactly.
the rapid. But what I've noticed with some of the disposable, the tubeless insulin pumps is that some people have a $0 copay, and there's not that upfront big contracted cost. So it is becoming more affordable for some, but as you've said, completely unaffordable for
And
others. And
and I'm
there's
a
definitely
big
a disparity there.
there is a disparity and we opt for the tubeless more so than not. But like I said, when you have to, especially if you're trying to be in auto mode and you're having to get your CGM and then get your pump, it eventually the costs start to kind of add up. And then a lot of people would then tell you, you know what, if I'm gonna have to choose between one of this and I'd rather keep my CGM.
Mm.
Um, but I mean, in an ideal world, I think getting everyone on a pump and maybe on auto mode is would be nice, but I don't think it's practical. And then even when it's affordable, some people just, I mean, and then you start having the problems of when you get kicked out of auto mode and you're because you've gone too far away from your device and now the sensor is not able to connect with the device and then it kicks you out and you don't realize you've been kicked out. So I don't know that the technology is quite there, but the good thing
I
is it's
Yeah.
getting better every year.
That's
So,
exactly what I was going to say. Is I know it, at least one of the companies has really looked at
hmm
that getting into the max delivery and the fact that kicks people out. Because I often say if you're traveling down the highway at 110 miles an hour and all of a sudden a blindfold gets put on, like that's when the tubeless and the CGM lose connectivity. You're
mm,
flying blind, so it's like whoa.
right.
Let, let's take the foot off the gas and pump the brakes a little. But I
Exactly.
think they're kind of removing a lot of that, recognizing exactly what you just said, that if somebody's going to stop an insulin delivery system, it's usually because of the alerts and the alarms,
hmm
or it's due to fear, or it just the settings weren't put in appropriate to what they really needed in the beginning. So I love that. I love that conversation. And I think that technology is only getting better, which
Only
is
getting better.
fantastic.
Yes.
Okay, so I think due to time, let me see. Okay, if you could change one belief that people have about diabetes, whether it's people who have diabetes and their belief, or the loved ones of people with diabetes, or just the general population who doesn't know much about diabetes, if you could change one belief that people have, what would it be?
Um, okay. It's actually two beliefs, but different sides of the same coin.
I'll allow two beliefs.
Yeah. So one, it's not a death sentence. It doesn't have to be. And I tell my patients this all the time. The it's never been more exciting in the field of diabetes because there's technology coming out, there are things in the pipeline, medications are the best they've ever been in like forever, ever, and it would only get better. So this is a disease that you honestly could manage so well that nothing as far as your risk factor, as far as the risks that the disease adds on your life, you can actually get it as close to zero as possible, like someone that does not have this diagnosis. Takes a little bit of work because we cannot negate the work that goes into it. But I also tell people, but it's actually good work. These
Absolutely.
are changes that you really should have, even if you don't have diabetes, these are changes you should make for your life anyway. So it's good work. It's not work like, oh my goodness, I have to do all this. It's
Mhm.
I'm paying in now. I'm paying into the my bank account of health and I will reap it. I'm going to start withdrawing when I'm older. When I'm 80 and I'm running around, traveling and doing everything I want to do, still living life at its fullest, you're withdrawing from the savings, from deposits you're making right now. So why not?
Love it. I love that so much. And we always tell people that this I hear from a lot of people, especially people who have type 1 diabetes, that they are thankful that they had diabetes because it has changed the way that they look at their nutrition and the way that they fuel their body and the way that they take care of their health and exercise, that they don't
Right.
know that they would have paid as good of attention and kept the upkeep of their body had they not had this to really have to pay attention to. And that's the mindset that I find the most beautiful. Like, you could have this where you have to take insulin and you find the gift in it. It's just
Right.
amazing. But I think also it's important to note, in the 1920s, not, 100, just under 100 years ago, just over, sorry, that this diabetes type 1 was a death sentence.
Was.
And so just to see how far, like, can imagine what the
Right.
next just 25 years will bring. It's
Right.
really promising.
Yeah.
I think that's a beautiful note to end on, is the promise of technology and the science that is going to bring about life-changing things.
So, what's
that
the
it already
flip side of
has.
the coin?
Oh, listen, we need to end on a high note, Richie.
No, no, no. This is stick the landing right here. We've
Oh,
talked about it can get better,
Yes.
but
The flip
but
side. The flip side of the coin is feeling good does not mean you're good.
yeah.
mm,
Yeah. We as a people, as a collective, honestly, we need to take accountability for our health. Um, sometimes I have people come, and this is just a side note. I have people come and I'm like, what's your A1C? And they're like, I don't know. My doctor told me it was okay. That's not good enough.
that's
Your,
very common, what you
your
just said.
body can care for you more than you care for yourself. Not even your doctor, not even your parents. Nobody can. So you need to take ownership for your health and just seek knowledge. I mean, we have everything almost knowledge-wise at our fingertips. if someone tells you something, even your doctor, and you feel like it sounds crazy, question it.
Mm-hmm.
Do research on your own. Educate yourself. But feeling good does not equate to being good. You don't have to wait until you start feeling bad to start making changes that you need that can elongate your lifespan and overall just make you just give you the good health that I know we all desire and want.
Absolutely.
Excellent.
That's so well said. You're
So,
here.
so Dr. Ogwo, if folks listening to this want to find out more about you or more about your practice, where can they go to get more information?
So you can go on TikTok. I make videos on
Cool.
diabetes and nutrition
Exciting.
and all of that. Yeah. And it's Cheri, CHERI.O.MD. That's the handle.
Cheerio. Love it.
Yes, Cheerio, exactly. Yes. And also you can check us out on sugarpros.com.
Okay, and we'll have the links to all those in the show notes. Thank you so much. You've been so incredibly gracious with your time. And
Loved having you on.
I loved having you. I loved having you back on the Diabetes Podcast.
Yes, sir. Thank you so much for having me. It's
Thank
good
you.
to be here and talk about diabetes.
Thanks for listening to the Diabetes Podcast. A big thank you to Dr. Cheri Ogwo. So many practical gems on getting out of A1C inertia, tailoring meds, and using data to actually change outcomes. You can find Dr. Ogwo on TikTok at cheri.o.md and learn more about her clinic at sugarpros.com, and we'll have those links in the show notes. If you enjoyed this episode, please take the time to give it a like and leave a review. This really helps to promote and sustain this free podcast and to get the word out to the millions of people worldwide that are struggling with type 2 and pre-diabetes, letting them know that remission is possible if you take action today. And if you have additional questions or need additional support, reach out to us at support@empowereddiabetes.com. Until next time, take courage. You can do this, and we can help.